Good evening, everyone. Good evening, sir.
Good evening. How are you?
So I'm doing fine. Uh, so all the aspirants have joined us. So shall we start,
Could
sir?
you see the site's slideshow? Could you see the PowerPoint?
Yes, sir. The presentation is perfectly visible. So, sir, shall we start?
Okay. Um, how many are? I just want to be sure how many candidates do we have here?
Uh,
Okay.
Six
Okay.
students right now. More will be joining us. So, good evening,
Okay.
all the aspirants present here. The topic for today is general topic. It is a CBS session, and the speaker that we have here is Dr. Fathy Elshazly. He is a specialty registrar at Northwest Deanery NHS Hospital, England. Yes, sir. So you can start. Thank you.
Okay. Good evening or good afternoon, wherever you are. Good morning, wherever you are. Today it will be a rehearsal about case-based scenarios according to the EDIC exams. Um, if you are if you're not aware about the structure of the EDIC exam, it's 2 days. It's being run over 2 days. The first day is about case-based scenarios, where you are going to have three stations. The first station, there is no special order for it. One station will be about biochemistry, where you have going to have some vignette, short vignette about or short case, and they're going to give you the lab results of this case, whether this lab is just renal function tests, liver function tests, complete blood count, or blood gas, and you expect to have a lot of blood gas. It's going to be about 8 cases over 12-minute period. And the second one would be radiology. We are going to see CTs, ultrasounds, X-rays, MRIs, and then they're going to show you 10 slides. And the third one is going to be about curves. These curves include ECGs, ventilator curves, ROTEM or TEG curves, intra-aortic balloon pump, pulmonary artery catheter, whatever the curves are there. And sometimes they are just innovating. They give you some new curves. Sometimes they're giving you EEGs or any other, or even monitor slides from a monitor bedside, and they ask you to give an interpretation of what you see, or capnography, or arterial line, whatever curves it is. And the second case as case-based scenarios, which are longer case. The hardest part of the ethic exam are usually in the first day. On the first day, where you are going to face case-based scenarios, because usually it's very limited time. It's about time management and about how to hold your nerves and pull yourself together during those about 30 slides, which are going to see. My advice, and usually, especially it's not difficult. It's not difficult at all, but it's about, because some of those slides some of those questions you might find them sometimes silly, and sometimes they are not clinically very relevant, and sometimes, for example, like the arterial line waves forms, it's no one depends on the can interpret arterial line waveforms form. I'm sure that you know a lot of consultants, great consultants, who don't usually interpret arterial line waveforms. And maybe you are not working, for example, in a place where you have got intra-aortic balloon pump or arterial line or pulmonary artery catheter. And so it's more difficult for those who have finished their training or their certificates long time ago, and they have been only working clinically. That's why usually it needs more work and more studying and more exposure to questions, especially regarding the curves one. The radiology are usually easy, and as you're going to find, usually easy, no tricks about it. And my only advice during the CBS, don't assume that there are there are no tricks in the CBS. They are just simple questions, and especially regarding interpretation of the biochemistry or the arterial blood gas analysis. Don't assume that there are tricks. Try to be as simple as you can. Do whatever you do every day in your everyday practice. For example, I know that if you attended the European Society of Intensive Care Medicine course, they will teach you how to use the Stewart method or strong ion difference method to interpret the blood gas. It's okay and fine, you can use it, but if you are not using it in everyday practice, don't use it in the exam. The exam is about time management. Try to be as simple as possible. Try to answer the question directly. The first thing comes in your mind, just say it. If you are not using strong ion difference or Stewart equation in everyday practice, and you cannot do it in less than 30 seconds, don't do it. And whenever you face difficulty in any of the slides, just ask to pass. And then you can return it back on. Because if the time slot, if there are 12 minutes passes without answering all the questions, they cannot give you the points for those questions or the marks for those questions. But if you say pass, then after you finish the question, you might return, after you finish all the questions, you might return back to any question you want to change your answer or edit your answer, or you haven't answered and you want to give an answer now. Okay, so whenever you face a difficulty or whenever you struggle, ask the examiner to pass this slide and you might return it to it later, because don't waste time. The most important part here is to pull yourself together and time management. And please, this is a rehearsal. This is just to give you an idea about the atmosphere of the exam. Without your participation into this session, it's useless. If you're not going to participate with me, and if you can open your cameras, I would appreciate it really, then so that you can practice the atmosphere of the exam. Because in the exam, you're going to open the cameras and you have to be visible all the time. And if you cannot open the cameras, just participate, please. Because if you're not participating, this session is useless. I'm not going to teach you anything new. I'm not going to teach you anything you don't know in this session. I'm just going to give you an example of what the exam will be. Okay? So let's start, please. This is an MRI and the CT for a 20-year-old patient who was admitted with low GCS. The MRI was before the procedure and the CT was after the procedure. Would you interpret, please, the findings of the MRI and the CT and specify what kind of procedure did the patient have? So I just need to see the participants. Let's go one by one. Anyone would like to participate? And would like to answer this question? Let's go by
infarction.
Huh? Who is it? Sorry.
Cerebral infarction.
Mr. John. Okay, Dr. John. Okay. Cerebellar infarction. That's great. Which lobe of the cerebellum is affected? Or
Left lobe.
the right or the left lobe. Okay. So, what do you think the procedure that this patient had? What is the procedure? Okay, could you see this? What is this? Okay. This is an EVD. EVD, which is being a catheter which is being inserted into the ventricles with patients who have got obstructive hydrocephalus in order to reduce the ICP and improve the cerebral perfusion. As you mentioned, you are right, Dr. John, it's infarction involving the right parieto-occipital loop and cerebellar hemispheres, worse on the left, progressive dilatation of the ventricles with basal cisterns effacement, likely related to cerebral edema. Of course, the hydrocephalus is not obvious into these cuts, but you would expect any patient with this size of infarction that he might develop hydrocephalus at some point. And the other CT, which is 1 day post-op, decompression of the lateral third ventricle. However, the posterior fossa remains crowded with effacement of the fourth ventricle. Don't skip. This is, of course, a radiological interpretation of the CTs, but you are not expected to say all of this. You are expected just to say the obvious findings. You are not radiologists. You are not expected to say anything detailed about the pictures. So you are right. It's infarction, cerebellar infarction. So the next question is, what you would like to do for this patient? What other imaging or investigation you would like to do for this patient? Any volunteers? Or Dr. John, would you like to answer this question?
Yes, I would like to do a cerebral angiography in order to try to detect where this or the obstruction is likely to be, most likely in the posterior brain, posterior circulation.
Very good. Well done. This is the cerebral angiography. Could you say what you can find, what you can see, please? Any volunteers?
Actually,
Okay.
it's like there's some
Involvement of
obstruction.
vertebral artery.
What? Sorry?
Yes.
Dr. Kumar, what did you see? Sorry?
Involvement.
Vertebrovascular insufficiency.
Where is it? Where is the insufficiency?
Right-sided.
Right vertebral artery.
Yeah, vertebral right-sided.
Vertebral. Okay, that's good. That's great. So as you can see, the infarction is mainly on the left side. It's more on the left side. But what you can see here, that the contrast is, there is a cutoff of the contrast in the right posterior cerebral artery. And the vertebral artery is barely visible here. So it's mainly on the vertebra. So if we can see the cerebellar, the left cerebellar infarction, and there is right, but for more on the left, then we would expect that the vertebral artery is the one affected actually. And so this, you are right, this abrupt cutoff at the distal segment of the right posterior cerebral artery, small caliber right vertebral artery with poor visualization of the right posterior internal cerebral artery. This is called what's called Poe-Hunter syndrome. It's a very rare syndrome. It's usually comes in the middle-aged patients, more in males than females. 55 is the median age. It's about known also as rotational vertebral artery occlusion syndrome, usually in those who have got some sort of cervical stenosis or arterial stenosis for any kind of reason, and associated with dizziness or stable consciousness in rotational movement, in severe or forceful rotational movements. So I know it might be difficult to bring you Poe-Hunter syndrome, but recently they started to, and especially in the short case CCS's clinical case scenarios, sometimes they bring some sort of difficult cases, but you are not expected to know everything, or not expected to give a strict diagnosis. You are just give us them some sort of differential diagnosis. For example, John did the right thing by asking for the cerebral angiography, and this is half of the mark of the question. The findings, you are not radiologists, you are not expected to see what everything. Just say or what you see. That you cannot see the contrast on the right posterior cerebral artery, just say this. I cannot find a lot. You cannot see the vertebral artery, just say this. That's considered the right answer as well. So the next question. 76-year-old man with quadriparesis, which appear to be more marked in his upper limbs compared with the lower limbs. Identify the key features of this T2 sagittal MRI, and how does this explain the clinical presentation?
So there is cord compression at the level of C2 and C6.
C2 and C6.
And C6.
Okay. How does this explain the clinical presentation then? It's compressing what now? So with this presentation, what do you expect the compression would be more? C2 or C6?
C2, sir.
C2. Okay. So this is C2. This is where the compression is? Sorry. This is C2. This where the compression is?
No, sir.
It's lower down, sir. This
Lower down, yes, sir. Lower down, exactly. So interbody fusion of C4 to C6, vertebral inclusive. This is what you can find in the pancake Okay, C3 and 4, there is posterior disc protrusion, as you can find with the yellow arrow, and C6 and C7 less marked posterior disc protrusion as well, blue arrow. These clinical features are consistent with a central cord syndrome. central cord syndrome. It's usually hyperextension injury, which happens usually in older age, in people above 65 or 70s, which occurs more frequently in the elderly with cervical spondylosis complicating hyperextension injury. Okay? The MRI, when they bring an MRI in the exam, they are very simple. They are very simple. I think that what you see in the C2 is just atlanto-occipital joint, which is usually, this is a normal. They find that some sort of these are fused together, but usually it is lower down. When you find that there is something wrong, you find that there are some spaces between the C3 and C4, and then these spaces disappear between C5, 6, and 7. At this point, then you have to, and there is compression in the spinal cord as well. Then at this point, you might give this answer. You don't have to give this answer. There is compression of the cervical disc. It's usually so simple. Don't complicate everything. Just say what you can see. And it's not, and by the way, you are not wrong. When you said C2, when you say anything which is, there are no negative markings here. If you say anything silly, which sounds silly, or anything which is wrong, but you are saying the right answer with it, they are going to mark only the right answer. They're not going to give you any negative markings. Okay, so if you say 2 and then you said C6, they might consider it correct. Okay, so it's considered
weakness is more in lower limbs.
Lower, so yes, that's why one of the features of what's called central cord syndrome. The central cord syndrome, usually the weakness in the lower limb is more than the upper limb, and usually in hyperextension injuries in elderly age because of the cervical disc prolapse, which usually, or any kind of which usually happens on those patients, especially those who have got some sort of spondylosis or atrophy of the interjoint cartilage. So this is a CT of a 35-year-old man post-cardiac arrest. What you can see, what you can see in this CT?
Diffuse
differentiation
Diffuse,
of white matter matter.
Okay, anyone else would like to say anything?
There's the diffuse verticalized.
Okay, let's make it in order so that everyone can have the chance to say. So let's start with who wants to answer this question? Altaf. Let's start with Altaf. Okay. Altaf, what could you interpret this the finding of this CT, please? Hello, Altaf. Okay, Benkaj, Dr. Kumar Benkaj, are you here? Okay, anyone else would like to volunteer?
And obliteration of ventricles. Diffuse brain edema, no differentiation between white and gray matter, and the obliteration of all ventricles.
Who's talking? Sorry, I cannot see that.
Muhammad.
Who's talking? Muhammad, Dr. Muhammad. Okay, that's good. That's good. So actually, that's the right answer. I wanted someone to say that there is some sort of high subarachnoid hemorrhage.
Yes, there's subarachnoid. Obvious.
Yes, subarachnoid. But actually, it would be the wrong answer. The right answer was what you said. The right answer, it is hypoxic encephalopathy due to or severe and causing severe brain edema and poor differentiation of gray and white matter. And that's one of the questions that they like in the EDIC exams, that they give you a picture, more obvious picture like this one, for example, where it shows that there is subarachnoid hemorrhage, but actually it's no subarachnoid hemorrhage. It's hypoxic brain injury, but because of the increased attenuation in the subarachnoid space, the blood looks like it is a hemorrhage. So how do you differentiate? By seeing, first you read the vignette very well. I didn't write the vignette here so that I can give you a chance to review the CT better, but just read the vignette very well. And then according to the vignette, according to the finding, you'll find that there is poor differentiation of the gray and white matter. There is brain edema all over. And then it's most probably, it's not subarachnoid hemorrhage. And this hypoxic brain injury. But if the vignette says something else, for example, after road traffic accident or after hypertensive encephalopathy, or after hypertensive emergency. At this point, you might consider to change your answer, but you have to look for the CT first. What you can find on the CT? Is there good differentiation of the gray white matter or not? Okay. So the key point here that sometimes in hypoxic encephalopathy or severe brain edema, the attenuation in the subarachnoid space might resemble the subarachnoid hemorrhage. Okay. Now, this is a patient, 50-year-old, who was admitted 7 days ago due to severe bacterial pneumonia and has been on meropenem and azithromycin for 7 days now. Now he has got abdominal distension, severe abdominal distension, and constipation, and the surgeons have asked for abdominal X-ray to be done. So by an abdominal X-ray, what do you see, and what are your differential diagnoses? Who's going to answer? Who wants to answer this question?
Okay, let me try, Dr. John.
Okay. John, you have answered before. I want to see someone else. I really appreciate that you are very active. That's the right thing to do. But I would like to give a chance to someone else. Anyone else would like to answer this question?
Sir, can I answer?
Arsha, okay, Arsha, please go ahead.
Sir, the film shows dilated bowel loops, probably toxic megacolon.
Dilated bowel loop, toxic megacolon. Any other differential diagnosis?
It's possible that we are dealing with C. difficile infection. Since he's been on
toxic
antibiotics.
megacolon. Is there any other causes of toxic megacolon that you are thinking about other than C. diff?
We have syndrome or
Ogilvy syndrome.
Sorry?
Ogilvy syndrome.
Ogilvy syndrome.
Colonic
Very good.
obstruction.
Yes. Well done. Well done. Ogilvy syndrome. Well done. So this is a plain abdominal X-ray, shows dilatation of the large bowel without obvious obstruction. This is an evidence of bowel edema with thumb printing and pseudopolyps or mucosal islands. The patient presents with toxic megacolon, which is systemic toxicity with dilated inflamed colon. Causes might be infective, like Clostridium difficile, cytomegalovirus colitis, Salmonella, Shigella, and or can be inflammatory bowel disease like ulcerative colitis. Okay, so always try to have some sort of differential diagnosis in your mind. Okay, well done. Let's go to the next one. Okay, this is a patient, the same patient. With CT chest of the same patient. What could you interpret the findings, please? Who wants to answer?
There is generalized lung fibrosis.
Okay. Anyone else? Anything else? Sorry, anything else you'd like to say?
Traction bronchiectasis.
Sorry?
Honeycombing.
So there is
Honeycombing.
ground glassing.
Lateral ground glass opacities.
Ground glass opacities. Okay. Anything else? Okay. Let's see the interpretation. Bilateral interstitial changes, small poly, traction bronchiectasis, diagnosed chronic obstructive lung disease, pulmonary disease. Okay, this is the diagnosis which was mentioned from the resource I gave. I took the image from. It is one of the OSCE books, which we all study for. This is their interpretation. Okay, but does it mean that you are saying the wrong thing? Actually, you said the right thing. If I'm going to put this image in any AI program like ChatGPT or whatever, the AI or Grok or whatever, the AI program, they will say the same finding that you mentioned. There are ground glass appearance, picture of interstitial lung fibrosis most probably. But sometimes we miss some small details like poly or traction bronchiectasis. If you said COPD only in an exam, they might give you just half the mark. If you said the interstitial lung fibrosis or ground glass appearance only, they might give you half the mark. Okay, so the key from the key point from this question is, first, trust what you think, trust your eyes, say what you see first, say what you see, and then give a differential diagnosis. Okay? Yes, and look carefully to the images. I remember in my exam, for example, they brought me an image of a patient with NGT inserted into the lungs. And there are some other findings, I mentioned them. But then, after I finished, the radiology usually is the easier station, and they finished quickly before the time passes. And then they asked me, would you like, it was the first slide, would you like to go from the start? I answered yes, let's go, revise again. And then it was the first slide. In the first slide, they told me, I told them the same findings, which I said, but they told me, look at the central line. What do you see? The central line was just 1 or 2 centimeters deep into the right atrium. And I didn't look at it because actually most of our patients, when the central line is a little bit into the right atrium, we don't do anything about it. We just accept it most of the time, as long as it's not very deep down. But they wanted to help me. They wanted me to say, yes, it's a little bit deep down and we have to pull it out about 1 to 2 centimeters. So I looked only for the frank findings and I forgot to look at the fine or little things. And this happens a lot in the exam. But usually the examiners, for example, if this question have 5 marks, they have 5 boxes to check. So whenever I'm going to say something, you are going to check on these boxes. So if you are not going to say the central line, they cannot give you the full mark for this question. Okay, and every mark at the end matters. Every mark matters. So just after you finish, yes, look at the frank findings, or the very obvious findings. But after you finish, have another look. And the best way to look at any X-ray or any CT is to have some sort of systemized approach. For either from out to in or in to out, or go through ABCD pathway, airway, breathing, lungs, see the cardiac silhouette, the central line, and its cardiac silhouette, and the major vessels, and the other attachments which are attached to the patient, including the central line, the ECG dot, and don't forget even the ECG dots. Don't forget to mention the ECG dots or anything else, because the ECG dots might hide something beneath it. Okay. So the next question is, elderly patient with acute abdominal pain, hypotension, and metabolic acidosis. He has got a past medical history of atrial fibrillation, congestive heart failure, recent hypotensive episode. Would you mind telling me the radiological findings and what's your differential diagnosis? Want someone else to answer this? Dr. Muhammad would like to answer this question.
In the intestinal walls.
Sorry, who's talking? I cannot see them. Who's
Dr.
talking?
Akshat. Akshat.
Akshat.
Okay, let's go. The problem that when I ask someone to answer, they don't answer.
This is a schemic.
Okay, say the findings first before giving the diagnosis. Say the findings. Could you say the findings? There is an arrow. What this arrow? What is this? This is a CT abdomen, right?
Air in the wall of intestine, indicating infarction, intestinal infarction. So
okay. What do you call this sign? What do you call the sign?
Emphysematous intestinalis.
Okay. So what's your differential diagnosis? Ischemic bowel, anything else?
Intestinalis.
Pneumatosis intestinalis, yes. What's your differential diagnosis?
Ischemic colitis or ischemic bowel or intestinal infarction.
Okay. This is pneumatosis intestinalis, as you mentioned. This is another CT. Refers to gas within the bowel wall. On the CT, this can appear as linear or papillolucences or submucosal or subserosal gas. Associated findings that you might find, if you can, sometimes they bring the portal vein gas window, bowel wall thing, which is a very bad sign, portal venous gas, bowel wall thinning, or lack of enhancement and mesenteric fat stranding. Its indication, as you mentioned, acute mesenteric ischemia or transmural necrosis. Okay, so can be ischemic, can be infective, can be but mainly they are ischemic, or can be inflammatory bowel disease as well. So always try to make some sort of differential diagnosis, and as much as you can start with the most common finding or the thing that you think that is the most relevant here, okay? So this is a 74-year-old male presented with sudden onset of abdominal back pain, hypotension, syncope. How would you like to manage this patient? What's the diagnosis and how do you like to manage this patient?
It's a case of pyelonephritis.
So let someone else, Dr. Muhammad, let someone else try it with this. Who wants to answer this? Just
it's a case of pyelonephritis, sir.
Pyelonephritis. Okay. Why is that? What are the findings?
There is a collection around the left kidney, sir.
Anything else you'd like to see? You'd like to add? What I'm saying now, you are going to experience in the exam. If you are saying something that is not right, or something that you miss some finding, other findings, they would tell you anything else. Anything else?
Bleeding into the tumor.
Hematoma. Who's hematoma where?
Bleeding into a tumor.
Bleeding into a tumor.
Sir,
Okay.
this seems like aortic dissection.
Very good. Okay, that's one. So we have 3 different diagnoses here: pyelonephritis, bleeding in a tumor, and aortic dissection. Let's see what's and of course the management will be different. Okay, the management of each thing, every
there is a false lumen and true lumen.
Okay, so this is actually a bleeding inside an aortic dissecting aortic aneurysm, and as you could find here, there is some sort of blood leakage from the aneurysm, and this hematoma, as you mentioned, and the clotted hematoma in the aortic wall, and this is a blood leakage, which indicates that there was some sort of perforation in the aortic aneurysm. Okay, it's not, we don't know if it's dissecting or not, but there is for sure perforation of an aortic aneurysm. The aorta is very bright with contrast. This is another picture, but the aorta here is very bright with the contrast, and this here the blood, and the rupture is here. This is another cut, a large irregular aneurysm with extensive bleeding around the aorta, and you can see the blood actively leaking from the area of this rupture. This indicates a very poor prognosis for the patient. So this is, I agree with all of you. If you if you are going to put this image on any AI imaging interpretation, that are going to give you different diagnosis. But always, and that's why always look to the vignette. Always look to the vignette. There is a vertebrae here, and there is a structure in front of the vertebrae. So the most common structure in front of the vertebrae would be aorta. Yes, it seems bigger than it should be, but this is the idea. They usually likes to give you some sort of indicators about what's the diagnosis. So the indicators here, the age of the patient, the presentation of the patient, they are giving you vertebrae and they're giving you structure in front of the vertebrae. Okay, so most probably this is rupture of aortic aneurysm. Okay, and there is hematoma in this aortic wall, which is clotted hematoma most probably. Okay. 47-year-old with history of alcohol excess presented with nausea, vomiting, and severe abdominal pain. What do you see in this image?
Okay, this is acute pancreatitis with severe pancreatic necrosis.
Okay, severe acute necrotizing pancreatitis. Where is the necrosis?
In the head of
around the head of the pancreas.
Head of the pancreas. Head of the pancreas. Okay, I want to organize it as much as I can, but the problem, I cannot see all the participants here, and active participants only who are talking. But okay, this is actually acute necrotizing pancreatitis, as you mentioned. Okay, how we are going to classify it, and how we are going to manage this?
It is classified on the basis of Atlanta classification: mild, moderate, and severe. Mild is when there is no complication and no organ failure. Moderate is when there is local complications and there is temporary transient organ failure for less than 48 hours, and severe is when there are local or systemic complications associated with pancreatitis associated with persistent organ failure for more than 48 hours.
Well done. Very well done. Okay.
Or bicep score also we can.
Very well done. This decrease or absent enhancement of the head of the pancreas, which define necrosis. The liver window setting difference in soft tissue contrast are made more apparent, making it easier to identify the necrosis. Okay, you can see the liver window and the soft tissue window. Can you see both?
Yes.
Hello.
Sir, can you explain 1 second?
Okay, this is okay. I'm not a radiologist, but we can see the liver window is about, it's the same cut, but it's about adjustment in the settings of the CT. When you see in the computer, any computer where they are using imaging for showing imaging for a CT, there are always you can modify the settings of how you view this image or this cut. For example, in abdominal, there are usually soft tissue window and there are liver window in the abdominal CTs. For example, in the brain CT, you have a bone window and you have a tissue window, and the same in the lung. In the lungs, you have in the CT thorax, you have a bony window where it's going to contrast on the bones, and you have what's called lung window, where it's going to contrast mainly on the interparenchyma, lung parenchyma, and there is a vascular window as well. So this is when the liver window is going to make the liver more bright, as you can see here, as if it has a contrast, but there is no contrast, and the other tissues around and the other tissues around become less bright than it. Okay, and the soft tissue window is going to appear more, is going to focus more on the other soft tissues like the bowel and the pancreas. The idea here that usually the necrosis of the pancreas appears more obvious in the liver window, than it appears in the soft tissue window. Unlike, for example, if you see that, for example, there is a mass, if you would like to see a mass, the mass will be more obvious in the soft tissue window more than the liver window. That's some sort of practicality that we are not expected to know this in the exam, but just the demarcations now, if you can see now, this is the same cut, but in the soft tissue window, you cannot find the necrosis is not very obvious. If you compare the head with the tail, the necrosis is not very obvious. But once you chose this liver window, the necrosis becomes more obvious, and there is an enhancement between or demarcation between the head of the pancreas and the tail of the pancreas. Can you see it?
Yeah.
Obvious, yes. Okay, the tail looks healthy and more structured than the body, which seems almost like there is no demarcation in the tissues, and thus it's usually structural differentiation. For example, when you are looking for a cyst, the cyst will be more obvious in a soft tissue window than it appears in the liver window. And this pseudocyst or cyst due to pancreatitis will find it more obvious on the soft tissue window. And as you mentioned, there are many classifications to pancreatitis: Glasgow classification, there is Atlanta classification, there is Apache 2 score, there is Ransom score, and there are, of course, usually managed conservatively according to the severity of the pancreas, and if there are, unless there are surgical complications which necessitate intervention or interventional radiology. And of course, at some point else, you need to treat the cause. Here, it's alcohol is the cause, but usually, and it is the most common cause in Western hemisphere. But for example, in the Eastern hemisphere, the most common cause is usually what? Cholecystitis. Okay, so cholecystitis, you will at some point you need to do ARCB or ARCB to the patient or cholestectomy if needed. Sorry. There is a question? Any questions so far? Okay.
No,
okay, this is an X-ray of a 40-year-old man who was involved in a high-speed road traffic accident. He was the front seat passenger when the car hit a tree. He was wearing a seatbelt. He's actually short of breath. What's your differential diagnosis? How will you confirm the diagnosis? It's a little bit tough question. I'm expecting that I can see a lot of good
Could it
candidates in
be
front of
diaphragmatic rupture?
Hiatal hernia.
Left hemi, left
Dr. John, yes.
hemidiaphragmatic rupture.
Left diaphragmatic rupture. Okay, how would you confirm the
Exenteration
diagnosis?
Of the stomach.
How would you confirm the diagnosis? How would you confirm the diagnosis, John?
We'll insert
By
any
CT scan. The
CT scan. CT scan, CT scan tab, yes, CT scan of thorax and abdomen. That's me. Yeah. And if the patient is unstable, you might try to insert an NGT. If the NG appears inside the thorax, it might appear as well that there is a diaphragmatic rupture. If the patient is unstable, to go to the CT. So
also,
as you mentioned,
yes, I think with scintigraphy also X-ray
sorry,
differential movement of both copula of the diaphragm, paradoxical movement of copula of diaphragm, so can also
of course, well, yes,
Fluoroscopy.
Fluoroscopy, yes, can be, but we're here talking about a trauma patient, and usually we want practical answers here. So either we want to either to diagnose it bedside if the patient is unstable, to be transferred to the CT, or if the patient can be transferred to the CT, let's go to the CT. Always in the EDIC exam, unlike any other, they like the practical kind of answers. Okay, you have got this patient in the in your unit or on your unit. What are you going to do for them? Are you going to either if the patient is unstable, you'll try to diagnose what's wrong with them bedside and then take them to the theater or to the operation room, OR. If they are stable enough, then if instead of going to the fluoroscopy, you better go to the CT then, right?
Yes,
so hemidiaphragm, as mentioned by Dr. John, pulled up from below, or might be ruptured. They might be pulled up or ruptured. We don't know. Given the history of severe trauma, the possibility of possible phrenic nerve injury should be considered. So if the diaphragm is intact, there might be possible phrenic nerve injury. Respiratory pathology, including atelectasis and rib fracture, can result in an elevated hemidiaphragm as well. Abdominal pathology, including splenic injury, hematomas, some splenic collections should be considered. Direct trauma to the diaphragm resulting in diaphragmatic rupture is an important diagnosis to exclude and can be caused as well by either blunt or penetrating trauma. Most diaphragmatic injury are usually on the left side, and as we all know that, because usually the liver is protective for the right side. So well done. As I mentioned, usually the radiology is the easiest part of the exam, so try always to so, a 40-year-old man was involved in a high-speed road traffic accident. He was the front seat passenger when the car hit a tree. He was wearing a seatbelt. He's acutely short of breath. What's your differential diagnosis and what's the management?
Right hemothorax.
Case of hemothorax with lung atelectasis.
Hemothorax with collapsed lung.
Collapse. Just try to be a little bit more accurate in your terms, okay? I know that attraction and collapse, yes, right lung collapse, okay, yes. Collection, you can say collection on the right side, most probably right hemothorax with right lung collapse, okay? So CT scan chest shows a large fluid collection in the right hemothorax, fluid somewhat dependent at compressive atelectasis. He's using your words, actually, the radiologist here. I took this from Radiopedia. The attenuation of the fluid makes this likely to be blood. Okay. This complication is best managed through the insertion of a large bore chest drain and replacement of ongoing blood loss and blood products, massive transfusion protocol. And thoracotomy may be indicated if about 1.5 liters blood. Usually this has been changed. I took it from a source, but actually it's 1.2, not 1.5. Okay. Or there is ongoing blood loss of 200 to 150 mils per hour over the next 4 hours in the presence of hemodynamic instability. So this has been changed recently to 1.2. Not recently, it was more than 5 years ago. 1.2, not 1.5. Okay? Well done. Yes, sir.
So the word atelectasis was wrong And collapse
I'm
would
not
be
saying
the
it's
right
wrong,
answer.
but you can say collapse if you are not very the resource here, the book which I took it from, used compressive athletics. But if you want to make it compressing, or compression, it would be or collapsing, it would be more accurate. But because athletics usually now is being referred to the some sort of the patient who has got some basal athletics due to prolonged recumbency or anything else. But usually we cannot see the lungs here, so we can use collapse or collapse. It's much, or compressive athletics, which will be much more accurate term. But anyway, it's not wrong. The EDIC examiners are the nicest, and they are, most of them, English is not their mother language. So feel free to speak whatever you want to speak. It's not a British exam. Most of the examiners are not English is not their mother language or mother tongue. So you can say whatever you want to say as long as you are saying the right diagnosis. Okay. 7-8-year-old man presents to the emergency department with a 3-day history of shortness of breath, fever, and productive cough. He is currently admitted to the ICU on nasal high flow. His respiratory rate is 32 breaths per minute. Heart rate is 120 beats per minute, and blood pressure is 101/62. His temperature is 39.4. Chest X-ray on day 5. This is chest X-ray which was done on day 5. Would you mind letting me know telling us the diagnosis and the management? Who was the volunteer?
Diagnosis is right-sided hydrothorax.
Right-sided what?
Hydrothorax.
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 How would you manage it?
Embayma, it can be embayma also.
Okay. How would you manage it?
Management with the placement of ICD.
ICT, okay. Why did you say embayma, Dr. Muhammad?
Fever is there, 39.4. Looks like this one, and most probably it will be infective.
Okay. So you are right, Dr. Muhammad. This is a right-sided embayma, because obviously you cannot see any pneumothorax at the moment. I know that whenever you can find the pleural effusion like this, clear cut, then you have to look upwards whether you can find the bronchoscopy markings or not. If there is pneumothorax, then most probably this hydropneumothorax or hemopneumothorax, and usually in the context of trauma. But patient now presented with pneumonia, and he is very septic, looks very septic, and we can find that there is no air here, and there is no pneumothorax, and so this line demarcates or indicates that there is some sort of air. But what kind of air? What kind of air would it be? Most probably it would be embayma, as you mentioned. Okay. So this is an embayma. The antibiotics have appeared to fail. The patient needs an intercostal drain, as you mentioned. Okay. Now we have finished. We have done with the radiology. Now we're going to the curves. Okay. Which is the hardest part of the exam, and usually most of the candidates who fail on the curves. Okay. Not because they are difficult, but just because sometimes they are silly questions, and or not obvious questions, or they are not giving the answers that they want you to give, actually. And I know a lot of my friends are examiners and the EDIC examiners, and sometimes they don't agree with those questions, but they are forced to ask those questions, and they're forced to mark according to the guidelines given to them or to the model answers given to them. Okay. So now I need a volunteer to answer this question. I need one. I don't want.
I can.
Can I try?
Presentation.
Yes, John. Okay, again, John. Okay. I like your enthusiasm, John. I like your enthusiasm. Okay.
I can answer.
Yeah.
Who's this?
It looks to me like Tosadis de Pontes.
Okay, sorry. Who's this? Who wants to answer?
Imad.
Ahmed. So Ahmed you will have the next question. Okay. Okay. Ahmed, you'll have the next question. Okay. We will have at least. So Tursad de Bois. Okay. What's the drug of choice to treat this?
Magnesium.
Question? Magnesium. Okay. And what's the management in case of hemodynamic instability?
Sorry, I didn't get you.
Management in case of hemodynamic instability.
Synchronize the
patient is hemodynamically
cardioversion.
stable. Please let him talk.
Okay.
Give him a chance, please.
It's a DC shock.
DC shock, I know. What kind of DC shock?
ICD.
What? ICD? Okay. ICD, I'm not going to insert ICD in a patient with hemodynamic instability or bariatric arrest, right?
Non-synchronized cardioversion.
Synchronized cardioversion. Synchronized cardioversion. There is, John, do you want synchronized cardioversion as well?
No.
No.
What?
No, just
what do you say? What kind of DC shock?
Unsynchronized.
Let's John answer first. Let John answer first.
Synchronized defibrillation.
Synchronized defibrillation?
Defibrillation.
Or asynchronized defibrillation?
Asynchronized.
Asynchronized defibrillation. Okay. Who agrees with John? Who agrees with John? Muhammad, you agree with John, right?
Yes, defibrillation.
Yes, sir, yes.
Who else?
No,
Ashok,
no.
you agree with John?
Just a defibrillation.
If the patient is stable, we can give medication. If the patient unstable, synchronize the cardioversion.
Okay. Who I want? The reason we have discrepancy here, and we have a lot of disagreement. So who would like to give defibrillation? Just hands up. Just hands up. Hands up. Hands up. No one hands up? No one.
Okay, I changed my mind. It should be synchronized.
You changed your mind? Okay.
Yes.
How you change your mind?
I go, yeah, because the patient, the patient has some pulse, only that is hemodynamically unstable. If it was pulseless, then I go for
what's your definition of hemodynamic unstable?
No, hemodynamic instability means that the patient is hypotensive and perhaps, of course, there's tachycardia, tachyarrhythmia, but there's hypotension. That's my understanding of hemodynamic instability. But if the patient if it's a pulseless rhythm, then I'll go for asynchronized that's defibrillation.
If the patient is what? If the patient is what? Sorry?
If the patient was completely pulseless, that's cardiac arrest.
Actually, the cause of torsades de pointes is R-on-T phenomena. So we want to synchronize and give the shock. If we give unsynchronized, it will again lead to R-on-T, and the etiology will not be cured.
Can we give shock? That's very good explanation, Bika. Very good explanation. Everyone, have anyone changed their mind after Bika's explanation?
If the patient has no pulse, so we will defibrillate. If the patient has pulse, if the patient is stable, we will give medication. If he is unstable, I mean if he has chest pain or hypotension, systolic blood pressure less than 90, we can give synchronized cardioversion in VTAC.
Okay. Dr. Ahmed, you are very systematic, and I like your systematic approach according to the book, right? Dr. Ahmed, have you taken ALS or ACLS?
Yes, every 2 years.
ALS or ACLS? ACLS, right?
ACLS, yes.
The American ones, right?
Yes.
Okay. So now I'm going to answer this question now. Okay. Actually, you are all right. He needs some sort of electrical therapy, but what is going to give defibrillation or synchronized cardioversion? The advanced life support, which is the European, and this is, and you are now doing the EDIC exam, which is European exam, never mention anything about Torsades de Bois in their manual about the electrical management. They haven't in their manual say whether synchronized cardioversion or asynchronized cardioversion for Torsades de Bois or lipomorphic VTAC. They mentioned in general, if VT is stable with pulse, synchronized. VT without pulse, asynchronized. Okay? We all agree about this.
Yes, sir.
But in polymorphic VTAC, Torsades de Bois, the ACLS American, and Dr. Ahmad, you can review your manual. They say in polymorphic VTAC, in Torsades de Bois to be precise, should be defibrillated, should give defibrillation shock. Why defibrillation? Why not synchronized? Because usually the monitor will not be able to synchronize based on this rhythm. They will not be able to synchronize with the R wave because it's actually bizarre shaped, and it will cause a delay in delivering the shock. Okay, I know that the internet, if you are going to look for this on the internet or the AI or whatever, there will be a lot of discrepancy. Some resources will say synchronized cardioversion, some resources will be asynchronized cardioversion. What matters to us? We don't care about the SLS, we don't care about the LS. What matters to us, what the European Society of Intensive Care want us to say. We all agree about this?
Yes,
Okay.
sir.
What we care about now is what the Intensive Care Society of European Society of Intensive Care want us to say. In their course last year in 2024, they said clearly that Torsades de Bois should be defibrillator. Should use defibrillation shock. Defibrillation shock. Should use the defibrillation shock. Asynchronized shock. And they mentioned more than once during the course, which was held or took place in May or March 2020, April 2024, if I'm not mistaken. March or April 2024. The Torsades de Bois should receive asynchronized defibrillation, not synchronized, asynchronized defibrillation. Okay, so if you have Torsades de Bois in the exam of European Society, say asynchronized defibrillation, because most probably, you have to be exact, because most probably the monitor will not be able to deliver synchronized cardioversion shock. And say your explanation for this. Okay, what about in your daily practice? What about in your daily practice? If you found Torsades de Bois and the patient is hemodynamically unstable and is not responding to magnesium, you might try to give synchronized cardioversion. You might try to give synchronized cardioversion. If the monitor is not giving the acquired version, if it is not delivering the synchronized shock, then turn off the synchronized button, turn it off, switch it off, and give them defibrillation shock. Give them defibrillation. And this is a recommendation actually of the Americans. Don't delay the don't delay the electrical therapy for synchronization. Give as fast as possible. Because patient, if becoming hemodynamically unstable, when Torsades de Bois, they are going to arrest in no time. So give the defibrillation.
So we'll give magnesium first, or we will go direct?
Defibrillation. Give defibrillation. In the exam, we are talking about the exam. In the exam, say defibrillation shock. Defibrillation. Okay? In your daily life, in your daily practice, whatever you want. It will not be wrong to give either synchronized cardioversion or asynchronized, anything you want. But give the electrical therapy as fast as possible. And what is faster here? Sorry, there is someone who's talking. What is faster here? What is faster is giving defibrillation shock. So the answer for this question is defibrillation, asynchronized defibrillation. Okay?
We will not mention magnesium.
Mention magnesium. This is the drug of choice. Dr. Muhammad. Question. Read the question very carefully, please. Diagnosis, drug of choice, which is magnesium. If the patient becomes hemodynamically unstable or in peri-arrest, give defibrillation.
Okay, sir.
Everyone is agreeing with me?
Yes. Yeah. Thank
Ahmed,
you.
Dr. Ahmed, are you agreeing with me here?
Yes, Dr. Fathy.
Yes. Okay. So, who gave the explanation for the synchronized cardioversion? Nafisa, I presume, or Rajan?
Me,
Bika,
sir.
Bika. Bisa or Bika?
Priyanka.
Priyanka. So, do you agree?
Yeah, sure, sir.
Okay. I know that this question would be very controversial, and it's very controversial on the internet. If you're looking to look in the internet, some resources say synchronized, some resources say asynchronized. But what matters to us now for the exam? Asynchronized. The European Society of Intensive Care will ask us for asynchronized. You can review their packs, review the resources on the website. If you are a member, you can review the resources on the website, and you can be sure of this answer. Okay. And if there is anything wrong, then you can message me or call me. But This is what they said in their course. And this is what mentioned in their manual. Okay? I'm sure I haven't read their manual for about this arrhythmias, but they mentioned clearly in the course. And the people who are giving the course are those who are putting the questions for the exam. Okay? And this is another ECG's variance of the Toussaint de Bois. Magnesium sulfate, as mentioned by Dr. John and Ahmed, defibrillation if hemodynamically unstable or degenerates into VF, overdrive pacing, isoprenaline to shorten QT and suppress ectopy. This is, of course, if patient is not in peri-arrested status, discontinue prolonged drugs, correct electrolytes, normalize potassium, magnesium, and calcium. Okay?
Okay, sir.
Okay. Everyone agrees? Anyone disagree? Okay. Agreement? Okay, that's good. So, who is the next? Ahmed, you're still with us, right?
Yes, Dr. Shaz.
Dr. Ahmed, could you interpret the ECG and tell us what is the most probable cause of hypotension in this patient?
Electrical alternance.
Please let Ahmed answer, please, so that we can give a chance to everyone to leave the atmosphere of the exam, please. Yeah.
The long strip reveal on small one.
Electrical alternance.
Electrical alternance.
So what's the most probable cause of hypotension here, Ahmed?
Massive pericardial effusion, obstructive shock.
You're right. Well done. Well done. This question came last year, actually, 2024. Okay. So this they just give you an ECG like this, and that's ask you about probable cause of hypotension in this patient. This is what is the cause of hypotension? That's the most probable. What is the cause of hypotension in this patient? Okay. Yes. Sometimes questions, and of course, in the exam atmosphere, these questions can be very difficult to answer. It's easy to answer it now, but in the exam, it might be very difficult to answer this kind of question. Okay, because you are looking for the B, you are going to look for the B waves, you are going to look for the T waves. Maybe there is some sort of bundle branch block or trifascicular block. Maybe there is. You are going to give we are going to give a lot of answers, but you might miss the right answer or the answer they want actually. Okay, so who's the next? Who's going to interpret this finding? 56-year-old male is admitted to the ICU post-liver resection. Someone would like to read the question?
Yes, I can.
Ahmed, give someone else. Bika, you would like to answer this question?
Yeah, sure. 56-year-old male is admitted to ICU post-liver resection, hemodynamically stable but has rising D-dimers and mild hypoxia. ROTEM is performed due to thrombocytopenia. Interpret the findings.
And what is the next question?
Would you start him on prophylactic anticoagulants?
Okay, so what's the interpretation?
Less than. So extreme CT is low here.
Can you magnify, please?
Muhammad, Dr. Muhammad, let her please give her a chance.
Just zoom out the figure so we can read.
Zoom out?
I think no need.
So zoom in, we can read the figures.
Okay. So I, by mistake now, I did, sorry, I give you the answer. So sometimes it's the ROTEM example, especially if you are not using ROTEM every day, it might be difficult. If you're not using if you're not working in a center, some centers do have thrombo take only, they don't have the ROTEM. So actually the NTEM and extem looks somehow normal. I know that Dr. Muhammad wanted to read the numbers of the figures. It would be more obvious, of course, in the exam, but the FEPTUM usually here, the idea here that the shape of the curve looks normal actually for the NTEM and extem. But what's really obvious and very frank that the FEPTUM here looks very thick. Very thick. Usually the septum is just a very thin curve. Okay, and as you see, all the numbers are normal. They are not in red, while here they are in red. So obviously there are something abnormal with the septum. I'm not going to explain the roton right now because it needs a whole lecture, about 1 hour lecture. But but I can refer you for a good. There is a very good actually lecture on the YouTube where the presenter explain the rotom very in details and give you a lot of questions about it. But in the septum, usually it's very thin, very thin. When you find it thick like this, that indicates hyperfibrogenemia, and this patient might have in a procoagulant status, hypercoagulable status. So when the curves looks normal, the numbers are normal in the entom and extom, but the septum looks like this. This means that even with this thrombocytopenia, which is expected in a post-liver resection, because this patient might have some form of thrombocytopenia because of the hepatic malfunctioning, but actually they are currently in this patient exactly in a hypercoagulable state. As long as they are not bleeding, as long as the patient is not bleeding, he or she are not bleeding, then, and with this kind of septum, then we should use the anticoagulation. This question actually, like this, exactly like this, came this year in the last exam in May 2025. They give you an entom, they give you an extom, and then they give you a septum like this. But they didn't give you the numbers. They didn't give you the numbers at all. They just give you the curves.
Ah.
Just the curves. They didn't give you any numbers. Okay? And they ask you this question: would you give them prophylactic anticoagulant or not? Okay? The question is that indication hyperfibrogenemia, and yes, you should give anticoagulation for the patient. Okay? Consider early thrombotic risk, microvascular thrombosis, and give them anticoagulation. Okay?
I have a concern. I have a concern, Dr. Fathy.
Yes, what's your concern?
I actually didn't look to the thickness of the septum. I looked to the CT interval. In the septum, it is lesser than in the entom. So I expected that it is corrected in the septum. So this patient is taking heparin, and this is the cause of thrombocytopenia, maybe from HIT, and we can shift the patient from heparin to bivalirudin or something like this.
Okay, maybe. Yeah, very good, very good, very good. But in the thrombocytopenia, it's going to be, they are going to let you know, if they are going to show you HIT in the exam, Dr. Ahmed, they're going to give you very strong marks about the HIT. Actually, the HIT came as well in this exam, but how do you know how did you show us the HIT? Okay,
I can
they give you a curve. They give you a curve with the platelet count. Okay, and they give you an indication. The vignette showed very clearly that the patient was some sort of heparin, low molecular weight heparin, and they give you a curve with the numbers on it. So, and they want you to say HIT. If they want you to say HIT about this, you cannot diagnose HIT from the rotom or the TEG, Dr. Ahmed. The rotom or the TEG.
So they will also mention heptem also in case of it.
Yes. Yes, heptem. Yes, as well.
Give the heptem.
They show you heptem as well. Very well done. Very well done. Yes, they will give you the indication that there is a HIT. They will show you the heptem. They will show you the thrombocytopenia trend over the previous few days. Okay, and you might think about, and actually your answer is not bad, is not wrong. You might say I will use, the question was not to use heparin or not. The real question was, you are going to use prophylactic anticoagulation or not? And the question would be yes. But if you are considering the HIT, and you can say this, but if I'm going to suspect HIT, I'm going to use any other agent other than heparin, like fondaparinux or herodines, liopridines. Okay, you can say this in the answer. You can say this actually in the exam, and they might consider it as well. That okay, that you know the answer, even if you didn't say that there is hypercoagulable status. For example, if you might not answer the first question, but you answer the second question. Yes, I'll give refractory anticoagulant, but I need to rule out HIT, and I'll give need to rule out HIT before giving the heparin. And if I'm suspecting HIT, I would use anything else like fondaparinux or the herodins. Clear, Dr. Ahmed?
Clear, Dr. Fathy.
Everyone agrees?
This was a question, I think, in last exam.
Yes. It's a similar one. It's not the same, but it's similar. Yes. But
yes,
they didn't give you any numbers. Yes. They didn't give you any answer. No, it was a patient with hypercoagulable status. It was hypercoagulable status. Yes, maybe it was HIT. Maybe it was HIT. But the question was hyper. In the last exam, they show HIT in another slide. They show HIT in another slide.
It was one by short case and progressed to hypercoagulable. I don't remember actually.
I remember that there was two questions. And both were in curves. Question was about HIT. They show a curve of thrombocytopenia trend. They take a screenshot from medical record and they give you the trend of thrombocytopenia, and you say what's the most probable diagnosis. The other question was about a patient with thrombocytopenia, and they give you the rotem, the entem, the extem, and the feptem. Or they give only the and then they asked you, and they didn't give you any numbers. And actually, the rotem, the first rotem was actually normal, looks normal. And they give you the feptum, and they ask you to what's your interpretation, and whether you consider antithrombotic or not. Okay, that was the question which they brought last time. The answer is that there is a hypercoagulable status, whether you would like to say HIT or not, but there is a hypercoagulable status for sure. And yes, we would give prophylactic anticoagulation. If there are two questions, you can answer one wrong and the other right, or you can skip the first if you don't know the answer and just answer the second one. Okay? If you cannot take the whole mark, at least take half the mark. Okay? Clear? Dr. Muhammad, would you like to add anything else?
Yes. I accept. Thank you.
No, thank you. I'm really happy with this controversy, which we are discussing now. A lot of discussions that mean that the questions are relevant to the exam. And this is another. So let's show you what's the normal entem, extem, feptem, and the healthy control. You can find that the healthy controls here in the entem and the extem, which looks like the previous one, and how the patient, for example, hypercoagulable status now in ARDS. Okay, this patient had normal septum, had normal extem, and the feptum was, as mentioned, there was abnormal, which indicates hyperfibrogenemia. Again, rotem and thromboelastogram is a big issue, and the big subjects needs, and I think there is, I'm not sure if there is on the Farz Academy website, there is a lecture or not for to explain it. But if you need some good resource about the feptum and rotem, you can go to the range physiology website, and if you want, we might arrange one day a lecture about it specifically, and bring all the possible questions which might arise about this subject if you want to. But if you don't have time, because the exam is approaching, you might go to the range physiology website. They have very good explanation, very good and simple and short explanation of the rotem. Okay. Now, sorry, I mentioned the answer. So could you I show you the answer. So could you interpret this curve, please? Anyone who didn't catch up the answer? Anyone would like to volunteer?
Auto triggering.
Auto trigger, maybe due to auto peep.
Leak in the circuit.
Leak in the circuit. What else?
Secretions in the circuit.
Water in the circuit.
There's
nebulizer
a
in
leak
the...
in the circuit. Tidal volume is not touching the baseline. It's
Okay, that's good. Read right, auto-triggering second to a leak by evidence of volume waveform, the green highlighted, not returning to baseline. Okay? Okay. Could you interpret this waveform, please, for me? Ashok, would you like to answer this question? Oh my God, a lot of I would like to give everyone the first. Nehdi, would you like Nehdi? Would you like to answer this question? Nehdi Agrawal? What? Ineffective?
Triggering.
Okay. Trigger delay. This was from an aerosol nebulizer placed in. Okay. Notice the waveform is below the zero. Okay. Waveform below the zero. Example of trigger delay on trigger eviter. This is trigger eviter. This is Bennett. So the first one is Bennett ventilator. The second one is trigger. The added flow from external nebulizer sources can cause trigger delays and apneas. The patient usually increases their respiratory drive and triggering is normal. Okay, so you can see that this trigger delay and then patients try to compensate. Trigger delay and then patients try to compensate. That's really sometimes usually one of the most difficult, other than the rotor and the tank, usually the ventilator waveforms. But usually now in the recent exam they're trying to make it much more easier, because most of the questions which were not answered correctly by the candidates usually about the ventilator, they stopped bringing any uncommon or rare or difficult waveforms at the moment. Okay, what about this?
Flow starvation.
Flow starvation. Well done. Well done. Flow asynchrony during volume controlled, as evidence from the scooping of the pressure waveforms. Okay, so the flow, this is another form of flow mismatch, versus when the patient's respiratory drive increases and the fixed set flow rate cannot provide enough assist to meet the patient's demand. And that's why the early recommendations are usually to hybrid modes or auto flow modes in order to make, even if you are in volume control, in order to allow the ventilator to adjust the flow according to the patient needs. Well done. So 68-year-old who wants to answer this question? This is pulmonary artery catheter. Anyone here is an expert with pulmonary artery catheters? Because I'm not actually expert with pulmonary artery catheter, but I have to study them for every exam, but because they are not very common now as used to be. Anyone is
wide descent is prominent here.
Sorry?
Wide descent is.
Can you read the question first?
60 years old, hyperdyspnea, potential.
So this ventricular septal rupture because of the ischemic artery disease, which is leading to equalization of pressures.
Okay. Well, what are in the waveforms which suggest this?
ACXVY. Here, X and Y descents are increased.
Okay. Are you good with the venous waveforms, with the right venous waveforms?
Right venous regurgitation.
If you see this in the CVP waveforms, what are you going to say? Just forget it's pulmonary artery catheter. If you can see this in CVP waveforms, what are you going to say?
So V is TR.
TR, right. So if you are seeing now in the pulmonary artery catheter waveforms, what's going to be?
Pulmonary artery catheter. First one is the
if you said, right, if it is CVP, it will be. Sorry. If you mentioned right, if you see it in the CVP waveform, you are going to say it's tricuspid regurg. That's right. Now it's in pulmonary artery. What's it going to be?
Here.
Just try to be simple as much as you can.
Maybe it is, first half is in a right ventricle and second half in the as the diastolic pressure is high, so pulmonary artery pressure?
Pulmonary artery pressure. Okay. So it's a big issue, of course. Well,
yes,
big issue, but
yes,
high. Okay. Okay. The answer is mitral regurg. Mitral is mitral regurg. Okay. So I know it's a big issue. It's a big issue now, but the question is that, sorry, this is a simple form. This is a recent paper which was reviewed all the waveforms of the pulmonary artery catheter. I've found it. It's not very recent, 2023, but it's about all the interpretation. Here, what you could see in the previous one was prominent and tall wave V wave, prominent and tall V wave. This is a hallmark of acute mitral regurg. Regurgitant flow during systole. Okay, deep papillary muscle rupture. This is what was the right answer for this. But if you go deep into it, I brought you in this slide all the possible waveforms which you can find on the pulmonary artery catheters or might come in your exam. But the point is that pulmonary artery catheter, most probably the wave they are going to bring you, the just simple ones, the most simpler waves. And usually they goes with the CVB waveforms. So if you are good with the CVB waveforms, just convert the valves from the right to the left. So if you said it's tricuspid regurg, it will be pulmonary mitral regurg. Okay. Sometimes they might bring complete heart block. If you can find Canon waveform, it might be complete heart block. If you can find high pressures, indication of high pressures like peaked A wave, it might be indication of left ventricular failure. Okay, so if you are not so good with the pulmonary artery catheter, but you are good with the CVB, convert the right to left. If you want to go into depth, you can read this paper. I shared it here. And there we can give you all the information you need about pulmonary artery catheters. And I showed here all the waveforms which you might see with the pulmonary artery catheters. Okay, including AVP dissociation. And if you good with the CPP waveforms, you will find that most of these waveforms actually coincides or goes with the CVP waveforms. Clear? So I'm not going to, of course, go through it now, but I've been talking through more than an hour. But if you want to read it with yourself, okay? Interpret this peak waveform, please. This question came last year as well. Usually in the PICO, we usually concentrate with the numbers and usually interpret the findings according to the PICO algorithm. But last year they made something new. They bring waveforms of the PICO, which is not common. And actually before this, I didn't know how to bring waves actually on the PICO machine, although we have PICO monitors, but I didn't know how to use it until I had this question in the exam. So could you interpret, please? Any volunteer? John, would you like to interpret it?
Maybe.
I will.
So the first one is that of normal cardiac output. The second graph is of low cardiac output, and the last is high cardiac output.
Well done. Well done, Navida. Well done. Actually, because all of some of us would be confused because in the arterial waveforms, it's vice versa. If the area under the curve is high, then it is good cardiac output. If the area under the curve is low, then it is low cardiac output. But here in the PICO, it's other way around. Okay, this is a comparison between the PICO and the arterial waveforms. Okay, sorry, I'm not having this. Sorry, the idea about the PICO waveforms. It's this arterial waveforms which stand here, lower stroke volume max, and this is the PICO waveforms. It's in the arterial waveform. They usually calculate the area under the surface area under the curve, and accordingly they calculate the stroke volume, and then they multiply it by the heart rate and give you the cardiac output. But in the PICO, which is in the left hand side, in the right, in your right hand side here, as mentioned by Nafisa, this is when the area under the curve is high, it indicates low cardiac output. When the area under the curve is low, this indicates low cardiac output. Or sometimes they give you some sort of faulty injection, because the scooping which is in the curve, or if there is very low curve, then it might be faulty injection or miscalibration. Okay. Well done, Navisa.
So it is not explained by me. It is explained by another female colleagues. I don't know the name of these colleagues.
Okay. Sorry. Who's it?
Me, sir.
Bika. Wow. I'm impressed. We're ready for the exam, Bika. You are going to the next one. Bika, are going to the next one? Okay. This intra-aortic balloon catheter waveform. Would you mind explaining interpret the curve, please?
It is normal.
Normal.
Deflation.
Okay. Actually, they are making it easier. Normal. Anyone else?
Diastolic augmentation. Okay.
Early inflation.
Early inflation.
Early inflation. What are the effects of the early inflation? Hemodynamic effects of the early inflation. Okay. This is poor diastolic augmentation in spite of appropriate timing. Okay.
After
The most
load
common cause of
reduction.
okay. Poor diastolic augmentation. It's not early, but only poor diastolic augmentation. Mean the augmentation, you're expecting that this wave to be higher, a little bit higher than the systolic one, or at least at the same level. But here, obviously, there is poor diastolic augmentation in spite of appropriate timing. The most common cause for this was patients who have got very poor cardiac outputs or hypovolemic. Okay. The balloon very too small for the patient. Usually this is a frequent finding in any patients those who are working cardiothoracic ICU. We will find that always we don't see the typical nice waves which we see in the books or on the internet. Usually you'll never find a typical augmentation. But before and most of those now, the intra-aortic balloon pumps now are being inserted either intraoperatively under fluoroscopy or in or interventional cardiology cath lab. So most probably they are in the right position. But the errors usually happens sometimes we have to rule out patients' error positions as well. Yes, we have to exclude anything wrong with the balloon, whether the size or the position, and the position can be confirmed easily with the X-ray. But sometimes the patient's factors itself might affect the interpretation of the waveforms or the proper augmentation. In this condition, there was poor cardiac output, which most probably occurs due to hypovolemia. Okay, on those kind of patients. So if you give him some volume, if he's hypovolemic, or if you improve the cardiac output through any kind of inotropes, you might improve the diastolic augmentation. Okay. Okay, clear? And there are, of course, other reasons that the size of the helium pressure or anything else. But it was just poor diastolic augmentation. Clear? Any questions regarding this?
No, sir.
Okay. So any volunteer for interpreting? And I know the intra-aortic balloon is a big issue, but I didn't want just to make it difficult for you, but I just want every one of you who is not very strong in one area to know his kind of weakness and concentrate. For example, if I'm not good with the ventilator waveforms or the asynchrony waveforms, I'll go and read more questions or read more resources about it. If I'm not good with ROTAM, because I don't have ROTAM, it's not something wrong in your practice. Not all of the hospitals we're looking at have got ROTAM. Some of them have got thromboelastogram TEG, which is different. Yes, the same concept, but different waveforms or different interpretations. Others don't have, for example, you are not working, don't have intra-aortic balloon pump. So it's not your fault, but that's what we need to focus, because in the exam, they usually bring this kind of questions, okay? And they don't expect you to go deep into it, but just they give you the common waveforms about it, okay? So anyone would like to interpret this waveform?
Late deflation.
Late deflation. Well done. So what are the effects of the late deflation? Hemodynamic effects of the late deflation?
Decreased cardiac output and aortic regurgitation.
Increase afterload.
Increase afterload, yes. Usually, the main idea of intra-aortic balloon pump is reduce the afterload and improve coronary perfusion. So anything goes wrong with the inflation or the deflation, it will affect those two parameters. Okay, so and the most dangerous thing is always late deflation or early inflation. Okay, because you want the balloon to be inflated at a certain point and to be deflated just before the during the diastole. You want the inflation to happen during the diastole to improve that because the coronary perfusion happens during the diastole, and to be deflated just before the systole. So that when it deflates just before the systole, it will reduce the cardiac output. So if it is going to be inflated too early, that means we are not going to provide the adequate coronary perfusion. If you are going to be deflated too late, that means that you are increasing the afterload and harming the patient. All the other faults which happens or errors which happen during, yes, they are not good, but they are not as dangerous as those two, early inflation and late deflation. Okay. This late balloon deflation increased aortic end-diastolic pressure and thus increased afterload and left ventricular oxygen consumption. Okay. So we have finished now with the curves. I have been talking for 1 hour and a half. Would you like us to go to the biochemistry or because I have prepared another 10 questions in biochemistry, or you would like us to try it one another day? Because I know that I've been talking now for 90 minutes.
Continue.
What do you like us to do? Carry on, or wait? Huh?
Continue.
Let's continue another day.
Okay, I need to make a vote now. Who wants to continue? Who wants to postpone? Could you just mention in the chat box? Continue or continue? Yes or no? Carry on? Yes or no?
Please continue, sir.
2 yes, 1 no. 2 no, 2 yes, 3 no, 2 yes, 3 no, and 2 yes. Okay. Now another day, 1, 2, 3, 4 no, 4 no, and 3 yes. 4 yes and 4 no. Oh, no. Yes. Sorry, another day. Another day.
So I think you can proceed, and those who cannot attend, they can see a recorded video.
Okay. Okay, we have got a draw now. 4 yeses and 4 no's. So I'll carry on, and those who doesn't want to continue, okay, you can come another day. But I'm going to just go fast with the biochemistry. But I postponed it till the end so that I wanted, because I knew that usually it is the easiest part of the exam. It's not the easiest, but usually I know that the curves usually make more controversy more than the blood gas. The easiest usually are the radiology. So now I need a volunteer to read the question, because who wants to read the question?
48-year-old lady brought to the emergency department confused and febrile, with a heart rate of 140 and a blood pressure 220 by 97. He appears mildly cachectic. Her blood tests are presented below. Sodium is 144, potassium 4.4.
No, just complete the question. You read the vignette, but just read the diagnosis and specific therapy. You can review the
Okay.
numbers and
Here,
just let us diagnose when you are ready.
sodium and potassium and chloride with a normal hemoglobin is okay. White blood count is 15.7. Neutrophil high. So by start normal, urea is high. Creatinine high, 253. Glucose also high, around 200. PK high. Calcium normal, phosphorus, magnesia, 83 is high. TSH is low.
So it's a case of
Thyrotoxicosis.
thyrotoxicosis.
Okay. Okay. Do you
Thyrotoxic
think this
crisis.
presentation is usually okay, thyroid storm or thyrotoxicosis? So what's the specific therapy?
Propylthiouracil.
Thiouracil. Okay. What else?
The
Beta blocker.
beta blockers
beta
first,
Iodine.
then antithyroid hormone, then iodine, and then steroids.
Okay. All of you are correct, but just when you are going to answer this question in the exam, just try to be a little bit systematic. Just ABCD assessment, support the airway, breathing, circulation. Always start your answer with ABCD assessment, and then we're going to do the specific management, like by giving either beta blockers and then give the propylthiouracil or the sometimes the carbimazole. I know that most of the resources now are using propylthiouracil. Usually is the first thing to be used, but even now some new resources that can use the azoles or the carbimazole or metimazole from the start, or at least from and after the first 48 hours. Different resources about it, but anyway, just don't forget the steroids, don't forget the beta blockers, and of course the propylthiouracil in the specific management, and of course don't forget about the Lugol's iodine and how to control the hyperthermia as well. And this hyperthermia is sometimes can be asked about it. What are you going to give them for the hyperthermia? Of course, don't mention paracetamol. Usually cooling measures. Those patients will need some sort of intubation, ventilation, and cooling measures, including cooling blankets or Arctic sun. Okay. This is the management. Decrease systemic sensitivity of catecholamine receptors and with peripheral conversion through beta blockers, reduce thyroid hormone synthesis through propylthiouracil and carbimazole as well, reduce the release of reformed hormone through Lugol's iodine. Don't forget the steroids, please. Treat the precipitant, which is usually sepsis, and supportive therapy.
What is the
so the next?
Sir, I have a question.
Yes.
Sir, I have a question.
Yes, please.
Sir, is there any specific rules that beta blocker should be given earlier than antithyroid drugs? Is there any
No, but
rules?
usually, no, there are no rules about it. Usually, are giving everything at the same time. Okay, but usually the hemodynamic stability in those patients happens usually because of the arrhythmias and the tachycardia. Okay, so sometimes the patient with hemodynamic and this patient presented with hypertension as well. So blood beta blockers will help you to reduce the conversion of T4 to T3 to treat the tachycardia and to treat the blood pressure. So usually beta blockers can be used. And of course, if the patient cannot take orally, you can always start with IV beta blockers as well. But there are no rules because usually in the patient, everything is being given at the same time. Okay, so
yes,
you will not lose anything by giving this before that. Okay. Unlike, for example, the pheochromocytoma, where this, for example, you have to be selective. Not
blocker.
be selective, yes. Yes, don't start with the beta blockers so that when, or sorry, give the beta blockers before giving the alpha blockers, because if to avoid any profound hypotension.
But in case of iodine, sir, we have to give a propylthiouracil firstly, then we have to give the iodine.
Yes, usually the iodine is the last thing to be given, but her question whether to give the beta blockers before the propylthiouracil or not. It's not about the iodine. Usually the iodine is not the first thing in on the management. Okay.
What is the significance of acute kidney injury and and the low platelets in the case?
This low platelets usually due to the sepsis. acute kidney injury usually happens either due to hypovolemia, which usually the patient presents with, or due to the primary condition as well, which is usually septic or sepsis shock in the sepsis in this patient. In high thyroid, or due to hypovolemia. So in any thyroid, most of the thyroid cases usually have a precipitant or excipiting factor, and most of this, whether myxedema coma or the thyroid tick, are usually sepsis. Okay, so most probably this creatinine, this high AKI or thrombocytopenia happens mainly because of the septic process. Okay, this sometimes can be some confounding factors. Okay, so don't always and that's what I was talking about in the beginning. Try to be simple all over the exam, but especially in the biochemistry, try as simple as possible. Okay, don't be distracted by any other findings. Sometimes they are giving you some distracting findings. Okay, just give the most obvious finding you see. Okay.
Okay.
Okay. So it is the most difficult part of the exam after the curves, is the biochemistry. Okay. And most of the difficulty is not because of the questions. The questions are usually straightforward. The difficulty comes from us, that we are making it complicated to ourselves, or maybe you attended the course and you are trying to apply the Stewart equation, or maybe you are assuming that there is some sort of a trick in the exam, in the question. Okay, don't assume that there are tricks. Okay, don't assume there are tricks, especially in the biochemistry. They know that it's usually a long vignette and a little bit difficult. Don't assume that there are tricks, please. Okay, don't try to be philosophical by any means, and don't do anything or apply any equations that you are not used to. Okay, if you can do these equations in less than 30 seconds, do it. If you cannot, no, don't do it. Just say what you can see. Okay, and regarding the blood gas, there is a very good lecture on the Farz Academy website. You can use it as well. They are not using the Stewart equation, but I think it's very good, actually, better than Stewart, because I like Stewart equation, but I don't use it every day in my practice, and I don't think it's, if you are not using it every day in your practice, it will not be relevant to the exam. It will be very difficult to do it in the OSCE exam, especially. Okay, maybe you can apply it in the written exam, but in the OSCE exam, it will be very difficult, especially if you are not using it every day. You have to manage your time properly. Okay, so yes. Who's going to answer? Dr. Ahmed, you want to answer this question?
No problem. Yeah, this in the ABG there is metabolic alkalosis due to hypokalemia.
Just read the question first. Regarding the vignette, always concentrate, especially with the vignette. You have to read the vignette and read the question, because sometimes you can read the question, you give the right diagnosis, but you didn't. For example, you didn't answer the second part of the question.
Okay. 58 years old male, traumatic brain injury and spinal injury, admitted to the ICU. Thiopentane sodium was started to control seizure. What are the possible causes of this blood gas? Maybe due to any dehydrating measure like Lasix, diuretics, or mannitol, or from the thiopentane itself.
Yes.
Also, maybe from the cerebral salt wasting can occur.
Okay.
Yeah.
Anything else?
There is something, but I am doubt to say. Cortisone or steroid.
Yes, corticosteroids. Yes. Don't be doubt to say yes. It can be anything. Anything can be. He might have had corticosteroids. Might have had the mannitol. He might have had the diuretics. There are no negative markings.
Yeah.
Say whatever comes to your mind. Okay.
Yes. This is regarding the first question. What should you consider when you correct the potassium? We have to correct potassium carefully, because when we stop thiopentane, rebound hyperkalemia can occur.
Very good. This is the right answer. This is the right answer.
This came in the exam, but I didn't solve it.
What?
This came in the last exam.
I didn't hear what he said concerning the correction of hypokalemia.
Yes, okay. Because came in the last exam, actually, in last May. The question was two-part question. There is a metabolic alkalosis, and they ask you, they're finding what is the cause of metabolic alkalosis in this patient. Patient presented with traumatic brain injury and admitted to the ICU. So what might the cause of the question? Either he received mannitol, received diuretics, maybe he received steroids, or maybe hypovolemic. This is the cause of metabolic alkalosis. The second part of the question, what would you consider correct hypokalemia? And this was the tricky part of the question, because they want you to know what is the basic pharmacology of thiopental sodium. Because the question now is about a patient who has got seizure. According to the European management of traumatic brain injury, there is a tiered therapy, tier 1, tier 2, tier 3. If you reach tier 3, that means that you have to induce barbiturate coma, and you might consider putting the patient on muscle relaxant. That means that this patient has severe brain injury, and that's why we are using thiopental sodium at the moment. So if we reach tier 3, then most probably the patient has received some form of osmotic therapy on the way, including mannitol. Okay, and he has got spinal injuries. So some people still old-fashioned might use corticosteroids as well, because you know that at some point that steroids was a crucial part of the management of spinal injuries. The other part of the question, which is the tricky one, that someone should know the pharmacology of the thiopental. The thiopental sometimes might cause a mild hypokalemia, but once you stop it, once you stop the thiopental, there is rebound hyperkalemia. And this patient already hypokalemic because of the diuretics, because of the mannitol, because of the steroids. And of course, if you have this patient in any of our units, you will continuously replace his potassium. And most of the ICUs now, especially in the Western world, have got protocols. These protocols usually followed by the nurses without returning to the doctor. Whenever there is for example, in the protocol of the nurses, if the potassium between 30 to 35, 30 to 3.5, replace potassium, give 40 milliequivalent over 2 hours. You will find it, or 20 over 2 hours. You will find it in any hospital, those kind of protocols. And the potassium is being prescribed BRN. In this kind of patient, you have to be very cautious when prescribing this potassium, because replacement, if they are going to follow the normal protocol and then you stop the thiopental, at this point, there will be rebound hyperkalemia. So before stopping the thiopental, stop the potassium first, or hold replacing the potassium for a while. Or be mindful that stopping the thiopental might induce hyperkalemia. So because in most of our ICUs, we aim for a potassium above 4 or above 4.5 in some ICUs. No, accept lower range at this point. Okay? Clear?
Clear. I didn't solve this question in the exam, and I failed. I didn't solve this question in the exam.
Okay, but at least you answered the first one. I didn't answer the second question correctly as well. So I had the same exam with you. I didn't answer the second question correctly as well, but I answered the first one, which was right. Okay.
Yeah.
Okay. Now, who is going to answer the next one? Any volunteer? Sorry. Oh my God. 38-year-old.
I can answer.
Anyone else would like to answer other than Dr. Ahmed? Any of the ladies are here. Oh my God. Sorry. My God. Something wrong with the ventilator, sorry, with the presentation? Yes. You have seen the answer now. So okay, Ahmed, go carry on, please.
I can read.
Yes.
38 years old male, 4 days post CAR T cell therapy, high fever, hypotension.
CAR T, they call it CAR T therapy.
CAR T cell therapy, high fever, hypotension, confusion, DLBCL.
Diffuse large B cell lymphoma, yes.
failed chemotherapy, preconditioning, fludarabine, and cyclophosphamide. Heart rate, tachycardic, blood pressure, hypotensive.
Is tachycardic, hypotensive, pyrexia,
Feverish.
thrombocytopenic, ferritin is high.
White blood cell low, CRP is high, ferritin is very high. Chest X-ray, interstitial infiltrate, echo, mild LV dysfunction. What are the differential diagnoses? Can be tumor lysis syndrome.
What else?
Can be also anaphylaxis from the medication itself.
Okay. Anyone else would like to add anything else? Anyone who could read the answer?
Is neutropenic fever.
Neutropenic fever. Okay, this is one of the differential diagnoses. Someone said something else.
HLH.
What? HLH.
Yes. Lymphohistiocytopenia.
I'm happy that no one has read the answer. Okay.
Can be can be sepsis.
Sepsis, of course, yes. These are all the differential diagnoses, but the right and what's your management?
Cytokine syndrome. One more. BD.
What? Sorry. What syndrome?
Cytokine syndrome. Cytokine.
Cytokine syndrome. Yes, that's. So, what's your management? Who says cytokine syndrome? Cytokine syndrome.
Yes, sir.
Yes, Bankers. What's your management for the cytokine syndrome?
Supportive.
Conservative. Okay. So you're right, Kumar. Is cytokine release syndrome. It's called cytokine release syndrome, CRS. Okay. Other differential. Sorry.
Cytokine release syndrome, symptomatic management along with IL-6 inhibitor.
IL-6 inhibitor, yes, right. Well done, well done. Who's this? Nafisa. Well done, Nafisa.
This came in the exam, I think.
This came in the exam, yes. It came in the last exam as well. This cytokine release syndrome, this is the right answer. Other differential diagnosis, sepsis, HLH, tumor lysis syndrome, and ICANS. ICANS is the severe form of CRS syndrome, but it affects the associated with neurotoxicity or central nervous system, or can be anaphylaxis or pulmonary embolism, like we all mentioned. Management, CRS can be graded using classification system recommended by the American Society of Transplantation and Cellular Therapy. Critical care evaluation are advised for grades 2 to 4. This is the grades of CRS. Usually from grade 2 to 4 is which require ICU intervention and ICU admission. And then go through that mentioned by Dr. Nafisa, interleukin-6 inhibitors, including tocilizumab and steroids, high-dose steroid therapy. Okay. In addition, of course, most of those patients still remain on antibiotics because you cannot rule out, they are neutropenic and you cannot rule out sepsis, okay, until sepsis is being excluded. And of course, other supportive management. Okay. So, who is next? Nafisa, I would like to answer this question.
So I can try. 34-year-old female present in the ICU with the acute dyspnea, pleuritic chest pain, and hypoxia. She is tachypneic, mild hypotensive, and has elevated D-dimers. CT pulmonary angiogram confirms the bilateral segmental pulmonary embolism. Prothrombin time 12 second normal, EPTT high, platelet count low. How do you confirm the diagnosis? What would we do if she becomes hemodynamically unstable? So they already told
that. Last exam as well. It came in the last exam as well.
Really?
Yes. What is this? And it comes a lot. Actually, it came the last exam and it came last year. They love this question. They love this question. Okay. So what's the diagnosis, Nafisa? I don't want anyone who had who entered the last exam, please, to answer. Okay. Let Nafisa answer, please.
How would you confirm the diagnosis? So it is a case of isolated.
Yes, isolated. Yeah.
Isolated rising of EPTT So to confirm this, I will repeat the test again, APTT, and do mixing study. And if the
So what's your differential diagnosis? If it is true, what's your differential diagnosis? Can be a fault. This is one of the differential, maybe faulty lab error. Okay, what's your other differential diagnosis?
It is a isolated APTT. If it is corrected mixing study, then it is anticoagulant induced, or if it is not corrected, then will be then some inhibitory factors in the blood.
Like what?
Like maybe it is antiphospholipid or anticardiolipid.
How would you confirm the diagnosis? How would you confirm the diagnosis?
So I will do the clotting factor study and also do the blood test for the anticardiolipin and antiphospholipid antibody.
Well done. That's good. What's called the blood test for antiphospholipid antibodies?
Sorry, I can hear you.
Lupus anticoagulant.
What do you call this test for the antiphospholipid?
Anticardiolipin, lupus anticoagulant.
Anticardiolipin, right? And what would you do if she becomes hemodynamically unstable?
If the as the patient is already I'm stable due to the pulmonary embolism, so I do thrombolysis this patient.
Okay, so you are right. It's the first differential diagnosis is antiphospholipid syndrome. It's thrombotic autoimmune disorders, usually more in females than males, usually induced or exacerbated by pregnancy. Warfarin remains the first line. Confirm the diagnosis by lupus anticoagulation, anti-B2 glycoprotein 1, and anticardiolipin antibodies. If we direct unstable thrombotic therapy IV or catheter-induced thrombolysis. Okay? Clear? They like this question. Okay? They love this question in the exam. The antiphospholipid is one of their favorite subjects. Okay? So don't forget, of course, catastrophic antiphospholipid syndrome. It can be a clinical case, scenario case as well. They loved so much the antiphospholipids in the exam and the pregnant cases. Okay? Who's next? Who's next? Who wants Dr. Muhammad, would you like to practice this one? Hello? Hello? Anyone want to practice?
78 years
Yes.
old gentleman, 25 maybe, with gifted, and mean 18. So local pneumonia is 1.06 microgram per minute to maintain map of more than 65. Region output average 40 meters per hour. The nurse is concerned about the hyponatremia. What is causing creatinine 71, urea 7.6, global mind, so potassium 1, potassium 2.2, chloride 59, PCO 23, BSL is 7.3. What is BSL?
Your sound is not, I cannot hear you. Little.
What is BSL like?
What, sorry? BSL. Blood sugar level. Blood sugar level. Blood sugar level.
Okay.
Any concern? What do you think it's reason?
So, sir,
This
it is a
differential diagnosis. Huh?
Yeah, and this is
diabetes
hyperlipemia.
Dr.
It is
Muhammad,
the cause
this Dr. Muhammad answer. This Dr. Muhammad answer. Then we'll. What's your differential diagnosis, Dr. Muhammad? Hello.
Hello, I am with you. This is maybe no, Addisonian.
Addisonian crisis. What else?
No.
What else? Hello. So you can answer. You can... Dr. Muhammad, the sound is not
Adrenal
clear.
cortical insufficiency. Adrenal cortical insufficiency.
Adrenal insufficiency. Okay. Anything else? Any other suggestions from anyone else?
Hypovolemic. Hypovolemic.
Syndrome of antidiuretic hormone secretion.
What's we know the syndrome? Inappropriate antidiuretic hormone secretion, right?
Yeah.
Okay, diagnosis
Yes.
right. You're that, John. The diagnosis is
Yeah.
SIADA.
I also think about SIAD, but here his patient is already hypertensive. It is not euvolemic. So that's why I hold my answer. Is it SIAD? In
Well,
this
he's
case,
hypovolemic because of sepsis. He's hypovolemic because of sepsis, and he's in a minimal dose. You see, when he's in a minimal dose of noradrenaline, 4.06 or low dose, and it might be because of the sepsis. Okay, and it's not severe hyponatremia. You are not going to do anything regarding this hyponatremia, right? You are not going to treat this hyponatremia. It's less than, it's not less than 120. And there is and the pneumonia is one of the causes of SIADA. Medications which she's taking now can cause SIADA as well. So hypoosmolar hyponatremia is with an appropriately high urine osmolarity for the low serum osmolarity and urine sodium more than 20 is almost enough to diagnose hypovolemia. Your answer that reasonable urine output suggests that he's euvolemic. Okay. And of course, all the other bloods are almost normal, and that's why this how we can diagnose that this patient most probably is euvolemic hyponatremia. Okay, and in the exam they are not giving, they don't want you just one diagnosis. You can give a differential diagnosis as well. Okay, and what are you going to do? Of course, you might try some fluid restriction, which wouldn't be practical, but issue that this hyponatremia doesn't need to be treated at the moment. It is above 20, and that's what we do. Just doesn't need to be treated, and we cannot apply fluid, and we have to let them know we cannot apply fluid restriction. I know that the model answer here, which from the resource I brought, is fluid restriction, but no one of us treats SIADA in our units with fluid restrictions, right? As long as the patient's hyponatremia is not manifested or not severe, more than 120. Clear? Anyone else would like to add anything else?
So what will be the treatment in this case? What will be the treatment for this patient?
According to what's written here, I brought what's written so that you are not going to count it on me. That is a resource, which I'm going to show you at the end. That is fluid restriction or fluid replacement.
No, in this case, how
but in this, nothing. In this case, we're not going to do anything. In this case, we're not going to do anything unless sodium becomes less than 120. At this point, we might consider giving him a low dose hypertonic sodium. This is what we are doing in our unit. We might consider giving him even some fludrocortisone if needed. But as long as the hyponatremia is not manifested or not symptomatic and it's not severe, as long as it is above 120, no need to treat. Okay, if it's hypovolemic, you might give some fluids. You might give some fludrocortisone if needed. You might give some hypertonic saline if it becomes less than 120. But in this case, nothing to be done. If this patient, I have got this, or if there is offending drug, for example, he is on some medication which might cause SIADA, for example, is olanzapine, for example, or haloperidol, then stop the offending medication. Okay, but fluid restriction, yes, it's an option, but for critically ill patient and patient with sepsis, it's really not practical. But you might give some limits for the fluids you are giving him, for example. Don't give him a liberal fluid intake. You might consider this. Okay? Or you might talk with the dietitian to increase the sodium content in the diet. You might consider this as well. Yes? But the most important issue is to stop the offending medication. Yes?
The confusion is that if we will, though they have taken the urine output and urea as euvolemic criteria for the question, but if we
that's very controversial. It's a very I agree. It's
if
a very
we will calculate the
controversial.
osmolality, it is more than 280, 290, sir.
Yes. Agree. It's very controversial answer. Very controversial answer. But what, and that's why we are discussing it. You don't have always to, the books are not always right. And I'm sure that you are not going to debate they are not going to judge the volemic status with the urine output, okay, or with the osmolarity alone. But and that's why you will find them here in the end of the answer. They are letting if the patient was hypovolemic, dry mucous membranes, lack of tissue edema, lack of volume edema, tachycardia, hypertension, then you might consider salt-wasting syndrome or renal cause or anything else, or diabetes insipidus. Sorry, renal cause. Diabetes insipidus cause hypernatremia, hyposodium. But it's about this question. Usually, there is no right or wrong. And sometimes they bring this kind of questions in the exam. They want to, but you have to just, if you cannot give you don't know what is written in their model answer. And that's why you have always to give differential diagnosis for them and give them the options. What are you going to do? And usually what are you going to do in everyday practice is the right answer. I'm going to ask for endocrinology input, for example. Okay. And I'm going to stop the offending drug if I can find any offending drug responsible for this. I'm not going to correct the sodium unless it becomes manifestations like seizures or reduced level of consciousness, or it becomes less than 120. I'm going to target euvolemia, and I would consider, if I'm suspecting if SADA is confirmed, I'm going to consider fluid restriction if the clinical condition of the patient allows us. Okay. That's the right answer. The answer is always to show that to them that you are a safe physician. You are going to consult endocrinology. You are going to keep the patient euvolemic. You are not going to treat the sodium unless the patient becomes symptomatic or sodium less than 120. Okay? Whether fluid restriction or not, that will be a very controversial statement, especially for critically ill patient. Okay? But you might increase, but it will be a multidisciplinary team approach. I might increase the sodium as well in the diet. I know that this kind of question would induce this kind of controversy, and that's what we need. But there is no only one, and they always have in their model answer paper, they have multiple answers. And as long as you're saying them, and they're saying some of them, they are going to give you the marks for it. You don't have to take the full mark. No one takes the full mark of it. Okay? Now, this question as well came last time. Any volunteers? Any volunteers? Hello? Anyone would like to answer this question?
Yes, sir.
Okay.
72-year-old male on corticosteroid for polymyalgia rheumatica present with fever, headache, confusion, and neck stiffness. He is febrile with a GCS of 13 and mild focal neurological signs. So my provisional diagnosis will be, sir, bacterial meningitis, as WBC counts in his CSF.
What's the cause? What's the organism?
Organism, Streptococcus.
Listeria.
Who's saying listeria?
72.
It's rods, not cocci, Anuj.
Streptococcus or
Gram
meningococcal.
positive. Streptococcal or meningococcal, both can be the different.
Listeria monocytosis.
Ahmad said listeria. Okay.
As is.
What's the treatment of choice?
Treatment of choice is, sir, ceftriaxone 2 gram IV, 8 hourly. Along with that, I would also like to go with vancomycin, 30 milligram per kg body weight, 12 hourly. Then before antibiotic therapy, just after antibiotic therapy, I would also like to give dexamethasone 8 milligram 6 hours.
Okay. Ahmad, who said listeria? Ahmad, you said listeria, right?
Yes. Yes.
Anyone agrees with Ahmad? Anyone agrees with Ahmad?
Yes. Yes, listeria it is.
Nafiza. Okay,
So
Nafiza. So what's the treatment of choice for listeria?
Ampicillin, then cotrimazole.
Just Ahmad, just please let Nafiza answer the question. Yes. What the treatment of choice?
Ampicillin, if there is a sensitivity to allergic to penicillin, then go for cotrimazole.
Oh, well done, Nafiza. This was actually because it's when you say ampicillin, the right answer is listeria. And when you say ampicillin, they're going to the next question will be, what if it's sensitive to ampicillin? The right question is ceftriaxone or chlorotrimazole or chlorphenicol, as mentioned. But if you can, not all of us, but if you are only really, if you are being asked with question that you don't know, then you have to be a little bit smart in manipulating it. For example, I didn't know that ceftriaxone. I told them I would call the microbiology. I would call them and ask them for sensitivity. Meanwhile, I might give anything else like gentamicin or meropenem. So I didn't say that ceftriaxone or chlorphenicol, but I passed because I mentioned the other options. Because I'm sure among their options there will be microbiology consultation about the sensitivity. You might, yes, ceftriaxone and chlorphenicol is the treatment of choice if penicillin is sensitive, but other agents, other things would be sensitive as well. So I know that that listeria is sensitive to gentamicin. I know that the listeria is sensitive to meropenem as well. Okay, but it's not. But the right answer, which was what said by Nafisa, that ampicillin if penicillin is sensitive, ceftriaxone or chlorphenicol. And don't forget microbiology and ID consultation. Okay. I don't know if I have. I think I'll stop here, but only 3 questions left. But we have been talking for more than 2 hours, and I think it's too much now for you. I'm sorry for this. I'm sorry for prolongation, but I tried to just to let you live the atmosphere of the exam. This is the resources I depended on preparing for this lecture, and I think some of the resources I didn't, and these are which I recommend that you study from. Those two first 2 books are Indian books. First 2 books, sorry, the first 2 books are Indian books and they are very good OSCE books as well. This is a ventilatographic book. It's a very concise book written by an American respiratory therapist. And the other one is the most important one. This one, which is examination intensive care. This is the most important book that I would like you to review. It's a very old book. They haven't made another edition since the 2nd edition. It's even recommended by the people who from the European Society of Intensive Care themselves. Some of the committee which are writing the exam are recommending this book. Yes, you might find some of the questions which I brought today, especially the chemistry, from this book. And some of the answers from this book, and I know that it would be very controversial. It would be very controversial answers, and they are not updated, of course. But it was written in 2012, so there will be a lot of changes. But they like bringing questions from this book. Okay, and believe me.
So can you share the PDF of these books in the group?
Okay,
Can
you will
you
not
share?
find it in Amazon. Okay, I'll share it, and if you want it, you can. I'll give you my email and my phone number. I can share it for you because this book, if you ask for Amazon, you'll find it by around $50 or something. And this book, the ventilator book, would want $20, but actually it's a very short book. So I have those books, especially those 2 books on. Online.
If there is,
I can send it to you. I can send it to you.
How can we contact you, Dr. Fathy, regarding this?
I'll show you. I'll show you at the last.
We really need it if you
I'll
can.
show you at the end. I'll show you at the end. I'll give you my email and phone book. These 3 books, which we usually study here in England for the FECAM, they are not EDIC style, but they can be useful as well. But of course, don't depend on them alone. Because they are not here. They don't contain a lot of curves, and they answer questions in a different way from the EDIC. The EDIC usually is a clinical exam, and usually it's they want direct answers. Here they started to be a little bit British or philosophical, but at least you can have some. You can practice some of the cases, some of the images, some of the ECGs, some of the cases which you might find, but they are not written in an EDIC style, okay? But they are useful if you want to review them. I can send it to you as well. I have them as a soft copy. I can send them to you if you need them. This is my email. This is my phone number. Just WhatsApp me on this phone number, and whatever you need, I'll try to give it to you. Okay.
So if you don't mind, please show last slides that you did not show. Please show
Which
slowly
one?
so we can see. So
Which one?
No, the one you did not you did not tell.
The questions?
Questions you not discussed. So we can at least
discuss.
take a screenshot. Huh?
Okay, you want to take a picture of them? Okay. You can take a screenshot. Okay.
For those questions which we did not discuss.
You want me to say them now or discuss them now, or you want to tell them?
Just at least to show the slides we can take a screenshot and discuss later in next lecture.
It's only 2 questions, yeah. Three questions, sorry, 3 questions. Okay. They are very long questions, so I didn't want I didn't want to bother you about them now because we have been talking now for more than about 2 hours and 15 minutes. So I'm very sorry but there was no other way to to show you CBS. To let you live the atmosphere of the CBS without this. I'm very sorry for that long, but this is what you'll have. It will be all these questions in the CBS. You will experience it in only 1 hour. 1 hour and 10 minutes, okay? But we have been discussing it for 2 hours now, and we haven't, still 3 questions we haven't finished. So that's why it's about time management. Okay? And I'm very happy that we had a lot of discussion and controversy during this answering those questions. Because it was very interactive session. But this is how we are going to practice, and hopefully good luck for all of you next time. Anything else you'd like to ask?
شكرا Dr. Fathy, and we are very happy by this session.
No,
and actually during the previous exam I failed in the CBS. I passed the clinical case, but I failed in the CBS.
Usually CBS, whenever you are experienced, usually you fail. But don't feel don't feel any pressure about it. Usually CBS is the worst part of the exam, and if the examiners themselves are going to have the CBS, they're going to fail. I have a lot of my friends who are examiners, and they don't know the answers to those questions. And some questions are very silly.
Concern is how to prepare.
The issue is to practice. No other thing is to practice. While practicing, you will find don't read too much. Don't read too much. Just practice. And the practice usually either from the OSCE resources and from the OSCE books and from the crash courses as much as you can. The crash courses. Don't attend long lectures. Don't attend just the crash courses. Practice with your colleagues who are going to take the exam as well, going to sit for the exam as well. Try to make a group and try to practice together. And those books are actually more than enough. Actually, those OSCE books are more than enough for practicing. And always, if you want to read from the shortest resource. Whether life in the fast lane, the range physiology. Just for example, I show you intra-aortic balloon pump. You didn't know this curve. I don't know the curve because I'm not working in the cardiothoracic ICU. So what you should do, go read a little bit about it in the range physiology or life in the fast lane. You might see there is a good video for it on Farz Academy website. You can review it. You can review it, any video, any short video and in the YouTube. Get away from the long lectures or long videos. Okay? Go only for the short videos and then the shortest resource. The shortest resource. The range physiology is a very good resource. And they show you the normal, the anatomy, and the abnormal curves. And then come back again and see all the curves that you need. Actually, this book, the Indian book, this one, Essential Critical Care, and they have all the curves which you might see in the intra-aortic balloon pump. That's an example. For the curves, for example, the curves, this book will find all the resources you want to see in addition to the other books as well from examination. From the other books, you'll find all the curves you need to see. And the issue is about practice. It's only about practice. For example, if you fail the curves, then you have to improve your knowledge about a certain area. And don't feel so pressure about it. It's about practice. It doesn't mean that you are not a safe physician or you are not fit for practice. It is just an exam. And the CBS, it's a very, put you under severe pressure. And the issue is about only the time management. My only advice, review questions as much as you can, reduce the reading as much as you can, and don't try to be philosophical. Just as simple as you can. The first thing come in your mind, just say it. Even if it's not the right answer, but it might be a possible answer. I might get a mark for it. You are not going to get the full mark, but you're going to get a mark out of it. Okay?
Sir,
Okay?
thank you for your excellent discussion. Sir, can you help me to sort out that? This is my first class in the Farz Academy, and it is a very excellent class. So I don't know, there is a more CBS class or how many CCS class, and
Yes.
anyone can help me to give me suggestion that how can I proceed with you guys. You are all excellent.
Okay. So you are excellent as well, Nafisa. So you are excellent. You have very good knowledge. It's about how to practice the questions according to the EDIC style. Okay. So for example, now you've practiced the first day. After this, we have another sessions about the second day and how to manipulate the CCS questions, which is much easier, but it takes a long time. They take you into a journey from the day of admission into the patient is being discharged from the ICU, or even if he dies. So it's about we can discuss, but my issue is what the same advice which I gave to Ahmed. Just practice questions as much as you can. Attend those kind of sessions, live sessions, as much as you can, because those live sessions, as you see, discussions, and let you leave the atmosphere of the exam. And we will try during the next few weeks with the Farz Academy to increase the frequency of practice sessions. Okay, yeah, and include and put more questions on it to let you have the experience of the exam. But you have to know what's your point of weakness. You have to identify your point of weakness. What you need to improve, whether the ECG, the curves, the intra-aortic balloon pumps. What do you need to move? Because most of you guys are experienced intensivists already. You just need to practice what the exam wants you to.
This session will be recorded.
Yes, it's recorded. It's recorded.
And
this is my phone number. And if you want, you can. We can arrange a meeting between you and you to give you some recommendations and advices. You can email me or WhatsApp me, and we can arrange a meeting anytime you are free.
Thank you.
Thank you, sir. Thank you, sir.
Thank you all. Thank you, sir, for this wonderful session.
Sorry, don't forget the feedback. Don't forget the feedback. Hello. Don't forget the feedback, please, and please review the lectures in the Farz Academy, whatever you want to review. For example, if you find there is a lecture about ROTEM, review it. If there is another lecture about ABG, if you find that you are not good enough with ABG, review it as well. And good luck for all of you. Thank you so much. Don't forget the feedback, please. The feedback which Fatma is going to send to you. Thank you so much.
Thank you, sir. Sir, it was a wonderful session.
Thank you so much.
So any students who needs any help regarding the PPT and all, you can all text me in WhatsApp. My name is Sana Fatma. I'm the course coordinator. I'll be helping you out regarding it. And we'll be having the next session soon. Thank you, everyone.
Thank you. Thank you so much. Thank you. Bye. Bye.